Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. I'm your host, Jacob Hutcherson. Today, I'm thrilled to welcome Chad Neilsen to the show. Chad's exceptional leadership spans not only the healthcare realm, but also extends to his service in the U.S. Air Force Reserve. As the Director of Accreditation and Infection Prevention at UF Health Jacksonville, Chad's dedication to patient safety and regulatory compliance is unmatched. In this episode, we'll have the privilege of exploring Chad's remarkable journey. With over 11 years of experience in public health, infection control, epidemiology, operations, and fiscal management, Chad's expertise is vast. Certified in healthcare management and infection control, and recognized as a fellow with FAPIC and the American College of Healthcare Executives, Chad's commitment to excellence is evident in his track record. Join us as we delve into Chad's mission to promote patient safety and quality improvement through effective procedures, program initiatives, and team leadership. From his role in the military to his numerous honors and accolades, Chad's dedication to service and leadership shines through every aspect of his career.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
How did you discover infection prevention, and then when did you decide to make it a career?
Yeah, so it kind of fell upon me, really. I went to school for my master's of public health epidemiology degree, and I didn't really know infection prevention at that point was a career track I could take. So then I rolled into a PhD program. Same thing, epidemiology, decided maybe this isn't hands-on enough for me. So I started looking around at jobs, saw lots of public health department jobs that were looking for epidemiologists, and I ended up snagging a chronic disease epidemiologist job for the state of Georgia, which was a blast. I loved my team there, but I was like, well, infectious diseases is really more interesting to me. So I started searching the job boards, and then I saw infection prevention as a job. Sounded like my background and my education matched to that a lot, minus some of the clinical things that an infection preventionist might do. So I was intrigued, and I started applying to infection prevention jobs and eventually landed one. And I've kind of gone up from there.
Awesome. Okay. So then when you first saw it, so you were coming from the Department of Health.
Mm-hmm.
So it looks like you took a job at UPMC. Mm-hmm. How big was that facility? And then what was the team makeup?
Yeah, so I was very fortunate to end up at UPMC, largely because they had a team that was already diverse. So they had a microbiologist on the team. It was a team comprised more of a multidisciplinary team versus the standard infection prevention office of nursing, right? And so at UPMC Presbyterian Hospital, that's a tertiary care major academic teaching hospital in the Pittsburgh region. And so they had a lot of things going on, very much like where I've ended up in my career with transplants and really difficult patient loads. They would get trauma patients sent to them from other hospitals. So it was a very complex organization. People are probably thinking, well, why did a Florida guy end up in Pittsburgh? My wife at the same time was looking at nursing opportunities because she had just finished her degree, her BSN, and she had family in Pittsburgh. So we're like, well, there's something at UPMC. Would that be interesting? And sure enough, I got offered that job at UPMC, and then she was offered a job at one of the children's hospitals for UPMC, and we kind of made that transition.
Awesome. So then, were you the first MPH? there?
So I wasn't, and I think that's probably why I factored well into how I was hired there. They already had at least one MPH on staff. They had a microbiologist. They had, I believe, a respiratory therapist at the time, a construction guy, an MHA. They had a very diverse team, but I was actually the second MPH epidemiologist that was hired there. So I think it probably increased my chances of getting an IP role back in, I guess it was almost 13 years ago when MPHs were sort of new to infection prevention. They already had one on staff. They were very forward focused in terms of diversifying their IP career, and I think that helped get me hired there.
Awesome. And I'll tell you, hospitals, it's changing a little bit now, but typically there's a lot of hesitancy to hire somebody out of public health. And I think there's some confusion on the overlap of public health versus working in a hospital.
Yeah.
I think individuals coming out of public health seem to think that they're far more equipped to do it than what hospitals give them credit for. But can you offer some insight? Like, how big of a transition is that, and where was it really lacking, like, as far as your experience goes?
Yeah, so I think when people say there's a lot of overlap between sort of the typical public health epidemiology role at a health department versus a clinical inpatient infection prevention role, there is a lot of overlap. What we don't get as MPH students and career professionals is some of the hands-on clinical care, right? So when I look at the job needs of infection prevention, half of it is tracking and trending diseases, epidemiology, understanding surveillance definitions, what is a surveillance definition, data analysis. MPHs get all of that, especially in the epidemiology track, where a nurse or maybe a respiratory therapist, somebody else, a microbiology tech who comes in from the job, they know the clinical aspect a little more than we do, right? So the line aspect of central lines versus Foley's versus VAEs and the different types of clinical things that can go wrong, that's where the MPH degree doesn't cover, right? And so as an MPH rolling into the hospital systems, I already knew, I'd say 50% of the job just based on my epidemiology background, but I did have to learn what a good central line dressing looked like, or what are the indications for a Foley catheter. I became much more clinical once I entered the hospital and had some of that training from the more clinical staff. But overall, it made sense very quickly.
Could you compare a MPH background versus like a micro lab scientist? Like, how do the transitions compare?
Yeah, so I think differently for everyone, right? So we have a lot of people who are microbiology techs or just straight microbiologists. They have a very high level knowledge of things like the antimicrobial profiles of the bugs and just microbiology in general, right? What's a pathogen in the respiratory tract versus the urine versus the blood? Those microbiology folks are so keen on that, and they're also very dedicated to getting the right answers in sort of the minutia of details, right? Whereas an MPH would have to come in, we know all the surveillance, we know all that. I didn't know that much about microbiology versus some of my counterparts who majored in it. And so I think each one of the positions that you would potentially hire for infection control, whether that's a nurse, a microbiology tech, or an MPH, there's some bit of it that they already know, and then they got to learn the other part of it, whether that was surveillance for a microbiologist or epidemiology for a nurse or the clinical background for me. I don't think any transition is necessarily harder than the other, but I certainly think that MPHs, now that we're so prolific in the field now and people are hiring us left or right, I think now a little bit of that tide is changing to say, oh, wait a second, we can teach them the clinical stuff, but they can help us with the data. And so I think these multidisciplinary teams can, comprised of all of these different types of backgrounds is really what a high-performing epidemiology team in a hospital should look like.
That's awesome. And how did you go, and I imagine this has continued throughout your career, but how do you go about picking up the clinical experience that you may have lacked coming into the role?
Yeah, so when I was first hired by UPMC, I knew the surveillance definition stuff. I knew the epidemiology, the data, the numbers. I knew how to track and trend. I knew all that. I had some background in hospital work because I had been in hospitals my whole life working in different jobs, not clinical, but administrative or otherwise. And so I was very fortunate that when I got hired by UPMC, they trained me with one of their most long tenured IP nurses there, right? And so she trained me on the health record, the EHR, the electronic health record. She trained me on some of the clinical stuff about central line dressings and kits and Foley catheters. And I was very fortunate to have that really experienced nurse do those things for me. And in turn, then she said, well, what do you know about study design? Somebody's asking me about that for a research project. Well, I can fill in that, quite nicely. So I think being taken under the wing of a really experienced nurse in infection prevention really did help me get it that much quicker. And then I was able to sort of, from there take off in the job, in the career, and then offer some assistance back to them because, just like I didn't get a lot of clinical stuff in my MPH epidemiology degree, our nurses, our BSNs or MSNs don't really get epidemiology at all in their degrees. And so we ended up having a very good partnership when we work with those nurses. So I was very fortunate to have a nurse, train me.
That's great. Now, it looks like after about a year, you left and moved back to Florida in a similar position.
Yeah.
But I don't know. I mean, a lot of folks say you have to be in the role for a couple of years before you really understand kind of what's going on. You had the public health piece before, so I imagine that timeline was sped up a little bit.
Yeah.
But how quickly did you feel like you kind of understood what was going on?
Yeah, so I think a hospital like UPMC or a level 1 trauma center like I currently work at, you get baptized by fire pretty quick, right? So having just joined the field of infection prevention, I did understand a lot of the epi, a lot of the disease transmission, but I had to catch up on the clinical stuff fairly quickly. I'd say it probably took me 6 to 9 months before I really understood and felt confident that I knew what I was doing. And once it clicks, it sort of clicks, but you're always continuing to learn more. Standards always change. Guidelines always have to be updated, but I'd say probably a good 6 to 9 months before I felt really comfortable. Maybe not in a position where I could necessarily lead a team at that point based on my knowledge, but definitely enough to be left on my own where a boss can, trust me and know that I'm going to do the definitions right. I'm going to get the data the way it needs to be, and I'm going to understand what a good dressing looks like.
And at what point did you go for your certification in infection control?
Yeah, so I went for certification in 2015. That was my initial certification in the fall that year. So I had been working as a infection preventionist for probably 2.5 years or so by the time I ended up sitting down and making that test for CIC.
And I guess that's back when there was a required 2 years before you were allowed to sit.
Yeah, that's right. It was the old requirement where you had to have somebody sign off and testify that you've had 2 years. So I couldn't sit for it prior to that. And I mean, frankly, I probably wouldn't have done as well as I did on the test had I done it sooner, because throughout my time at UPMC and then back at UF Health Shands when I moved back there, you continue to gain knowledge that is necessary to really pass that certification. So I might not have been ready before the time I took it, but I did feel confident when I took it that I would pass on the first time, and I did. So
awesome. And then I'm assuming personal reasons brought you back to Florida?
Yeah, anybody who's lived in Pittsburgh knows it's cold and it's snowy for like 9 months out of the year, right? And I happened to have an opportunity back at UF where I had graduated from. But I loved Pittsburgh. My wife and I, like I said, she had family there. So she had a very, very difficult job at Children's Hospital in Pittsburgh, working for the NICU department there. And I think, between the gray, cold winters and the amount of snow that we had to deal with, it felt like, yeah, this Pittsburgh experiment, it was fun, but we're ready to head back south where it's sunny.
Yeah. So what's interesting about this, and I understand that the certification wasn't as prevalent maybe back in 2014, 2015, but you landed 2 jobs as an MPH with no CIC, which is, a little rare. Yeah. So I'm curious, it didn't sound like you knew anybody at UPMC. That was kind of cold. I imagine there was some networking that went on to get you back to where you graduated from, maybe.
Yeah.
But if you could go into kind of how you, I don't know, how you interviewed or how you conveyed a message that like you knew what you're talking about and do the role.
So I think one thing that really helped me get my first infection prevention job, aside from the fact that I had an MPH and I really knew epidemiology, I did do a lot of volunteering during my graduate work in the hospital to try and learn about infectious diseases from a clinical perspective, right? So I had undergraduate research, I had graduate research that involved hospital folks doing infection control. So I always tell people, if you want infection prevention experience, and especially back then when things like the AIPC didn't exist and hospital internships weren't common, just get involved in infectious disease research in the hospital if you're attached to an academic health system. And that really helped. So when I did interview for the UPMC job, having not been an infection preventionist before, I think they saw someone who knew infectious disease on my background from the work I did in graduate school. I had the epi background from the Department of Health as well as just my in general degree. And I think they probably took a chance on me. Now, when it came to Florida, it was funny enough. We saw that position pop up. My wife and I decided, yeah, let's move back south to be closer to family and more temperate weather. I saw an opening at UF Health Shands in Gainesville, where I got my degree from, and I applied. Well, as luck would have it, the medical director at UPMC was cousins with the medical director of infection control at UF Health Shands, unbeknownst to me. So when I walked into my medical director's office, after interviewing in Gainesville, she said, "Hey, you just met my cousin Nicole down in Gainesville," and I was floored. I was like, "Uh-oh, cat's out of the bag." And she's like, "Of course I told her she should hire you, So there was a little bit of inside job going on there, but I didn't even know about it. So my medical director at UPMC was Carlene Muto, who is prolific in the infection prevention field for medicine, and she was really awesome in being able to recommend me to her cousin to hire me. So sometimes it's wild. A very small world out there, especially in infectious diseases.
Yeah, that's wild.
Yeah.
Okay. All right. At some point in all of this, you enlisted in the Air Force, it looks like. So you got a pretty lengthy military stay. So first off, how does that even work? How do you pull this off? And then two, is there any overlap in your job roles at all?
Yeah, absolutely. So I had this great idea that I wanted to join the military after graduate school. I sort of flirted with the different branches, but I kind of always knew I wanted to go Air Force. I have a Air Force family. My grandfather did 23 years and uncles who were in the Air Force. And so I knew I kind of wanted to do that for a variety of reasons, right? You want to serve, you want to do something kind of bigger than yourself, but also, right, we had mounting student debt, right? The MPH degree is not cheap, and it's only more expensive now than it was back in 2009 when I graduated. So in 2012, while I was working in the health department, I decided, well, I'm going to find a job in the Air Force Reserve because I think that was an easier pathway than going straight active duty. I didn't know that I wanted to commit to active duty yet. So I joined as a reservist, as a public health officer in the Air Force Reserve. So in the Air Force, to be a public health officer, you either have to have a MPH epidemiology degree or you have to be a DVM, a veterinarian. And so I met the ability to become a public health officer with Air Force Reserve and kind of have gone from there. So I enlisted, well, I shouldn't say enlisted, I commissioned as an officer in 2012 when I was working in Atlanta, and now I'm on year 11 as a public health officer. And the role, there is a lot of crossover between infection prevention and a public health officer role in the military. I think for my Air Force job, it's a lot more broad. So it's everything from, tracking infectious diseases, trending, surveillance definitions, and reporting to health departments, but it's more broad to include threats on base, right? So you have to do food inspections in the cafeterias, you have to inspect MREs, you have to do water testing, you have to do an entire what we call a vector surveillance plan. So do you have mosquitoes on your base or other types of things? So it's kind of like operating as a one-man health department for the entire installation that you're assigned to. I've been involved with the Ebola pandemic, sort of pandemic in the teens, where the Air Force Reserve had me, advising people how to clean out the back of C-17 cargo planes if they got an Ebola patient, right? So these are all things that, from infection control to public health, don't really naturally exist in the military. So you have some guidelines, but it's really up to you to figure it out. And, that trial by fire, again, really came through the COVID pandemic when that exploded. That was an entirely new threat of infection prevention that the Air Force and the military in general was not equipped to handle. So they kind of looked at people like me as a public health officer and said, well, what do we do? And I've got, stories of the different things and different, groups and airframes I was forced to kind of work with and try and figure out how to clean, how to keep safe, how to plan things. So there's a quite a bit of overlap between the Air Force and work that I do there and what I do in the hospital. But I'd say probably on the Air Force side, it's a lot more broad.
And I'll say, looks like, you've done the Air Force. Mm-hmm. It looks like the entire time you've been at Florida for the last almost 10 years now. I would imagine they're pretty accommodating. How much time does this take from your hospital role?
Yeah, that's a great question. And to be fair, it varies year to year, month to month, right? So the worst case scenario happened during the COVID pandemic, right? So in 2020, we were sort of starting to prepare in January for what we thought was going to come. And on the hospital side, we were kind of rewriting policies. We were beefing up on PPE. And then the first case dropped. And the state of Florida said, oh, you're the only public health officer in the National Guard in the state of Florida. You're coming with us. And so the first case of COVID hit, and I was pulled by the Air National Guard, and I was gone for 3 months during the start of the pandemic. So as to how the hospital has handled my leave and my continuous deployments and things, they've been great. So all employers have to follow certain federal standards when it comes to reservists, right? They have to let us go if we have orders. They can't demote us. They can't fire us. They have to keep our position no matter how long we're gone. But it's also understood that different organizations put different pressure on people as well, right? And luckily, I've been part of organizations, whether it was UPMC or Shands Gainesville or in my current job, that they're very understanding of my military work. They believe that, right, if I get called up, they know that I'm doing something bigger than just the hospital or bigger than, just this community. And so they've always been very accommodating. On the average month, I have drill a couple days a month, but depending on deployments and different things, it could vary widely. Even here in the month of August, I've been on military orders for probably, 10 days total in the month of August, and it's only the 21st, just because of a deployment. I had to go train people down in the Caribbean how to do public health and infection control. And so just month to month, it could vary greatly, but the hospital's been very accommodating. All of my organizations always has been, and that's made my life a lot easier, not only as an infection preventionist working for the organization or a director leading people, but it also truly helps our national security when they allow me to come and go as I need to.
What, and I understand there's some legality behind
Sure.
this, but what's your gut? Do you feel like this is, if you were pursuing another position, or even when you're pursuing the two positions that you've held, do you think people look at that as an asset or a liability?
Yeah, definitely an asset. I don't think I've ever come across a job or a recruiter or someone who said, oh, you're military and you're National Guard and, we don't like that. Generally speaking, especially at the level I am, I'm a major now in the Air Force and heading towards 05, Lieutenant Colonel. They know that you've been a leader for a long time, right? And that speaks volumes. I think one of the reasons I got my job here at University of Florida Health Jacksonville was because they knew I had been leading people in the Air Force for longer than I'd been leading people in the hospital, right? And that's something that the military is very good about, is that once you get your rank as an officer, you have people. You have people to take care of, people to lead. And I think that has helped me kind of climb the way I have in the civilian hospital world, because I've been leading people a lot longer on the military side than I have in the hospital, and they see that as an asset. And my flexibility and my ability to sort of get things done at all methods and ways, despite costs being expensive, they see that you can squeeze blood out of a turnip because I have to in the military. So I think it's been a big asset, and I think everybody's been very gracious to me in allowing me to do my work as a military professional, as well as a leader in a hospital.
Yeah, that's outstanding. Thank you for that.
Sure.
Too. So, and that speaks to your progression. I mean, you were in a staff role for a year and a half in Florida, and then looks like promoted to a director from there. How did that go down? Was there an opening that you applied for?
Yeah.
Did they push you to a different hospital within the system, or what was that?
Yeah, so I wasn't necessarily looking around for another job. I think we had some growth and some leadership changes that were happening at the Gainesville campus of UF Health. I was interested in the director role there, but they chose to go with a different direction, and that's fine. But then this director job here at UF Health Jacksonville was created, and so it pops up on the internal career boards. Hey, this position's open, and so I said, well, I've only been in infection prevention a few years. I don't know. I'm not even certified yet. We'll see. I'll throw an application in. We'll see what lands, right? And fortunately for me, I got a call. The recruiter from UF Health Jack said, hey, you're an internal candidate. We saw you pop up. Do you want to interview? And I said, sure. And then I got here to a very, very skeptical group of nurses working in infection prevention who saw me as this young kid who didn't really know what he's doing, and he's not a nurse, but luckily they chose to hire me, and we've done great things since.
It's awesome. So, was this the first non-nurse as a director in Jacksonville?
Yeah, I believe it is. If I
Okay.
think across all the different hospital systems in Jacksonville, I was probably the first non-nurse hired to lead a hospital infection prevention team. But since I've been hired here, I think the other hospital systems, every single one of them has hired an MPH or an MPH RN to lead their teams since me.
Wow. So, okay, let's see. You said you caught a little bit of flack probably for being a non-nurse in that role. Obviously, you had leadership support because you got hired, so you had the backing you probably needed. But
Yeah.
Can you talk through some of the challenges you faced and how you ultimately won the nurses over, and kind of what you would recommend for anybody else walking into a similar situation?
Yeah, and it's a situation that still proliferates out there, right? I mean, we still see every day hospitals are looking for RNs only or BSNs only. And for purely infection prevention leadership roles, it's really limiting their ability to get people and good applicants, right? I mean, it's one thing if the IP director at hospital A also has to run employee health and give vaccines and stuff. I get the RN requirement there, but it can be a limiter for some roles. And so I think for those who might be looking to break into the field and win favor, especially amongst more clinical teams, I think it's really meeting them where they feel there's a deficiency, right? When I walked in here to UF, I had a group of skeptical nurses looking at me. And I think by showing them that, hey, I really know what I'm doing. I already know the clinical stuff based on my previous experience. I know the surveillance material. I know this job, and then proving it to them by helping them through their challenges, I think really got me buy-in with the staff. I think showing the staff more than anything that I'm not here to necessarily tell you how to do infection control. I'm here to make your jobs easier in infection control and help lead our department in a direction. I think that really speaks volumes to staff and helps get over any kind of hesitation they might have in hiring a non-nurse. I met that staff where they needed to be met. They were a department that were run down, that everybody was blaming them for everything. They didn't have good support. I mean, they couldn't even get basic things at the time, like, working printers and computers and things. And so, when I walked in and said, well, how can I help you do your job better? And they gave me a laundry list of things that they felt like they've been neglected for. I started picking those things off, and I started saying, okay, well, we got this going on. Or, you know what? You tell that person to talk to me next time instead of you. And I think that really got the buy-in of the staff, that they knew I knew what I was doing because I showed them. I helped them do their jobs easier, and I took some heat off of them. And I think for a leader, that's what everyone wants, right? You want to work for somebody that protects you from undue management scuttle, but also gives you the tools you need to succeed in your job. I can't ask my staff to do their jobs if they're not being given the things they need to do that, right? And so I think that was a big part of me winning over our staff here, showing them I know what I'm doing, and then helping make their jobs easier. And that's going to win over staff every day, no matter who you are or where your background is.
Do you happen to remember a specific story or like a moment where you just like, oh yeah, I just won him over, or like that was a tough one, but like you feel like you made it?
Man, I think,
I know I'm putting you on the spot here.
yeah. I think it was, if I think back really, the biggest challenge I ever had was with my staff here at UF Health Jacksonville. When I came on board here, I mean, it's kind of the joke amongst the C-suite here now, right? So if you Google UF Health Jacksonville in 2013, at the time, the then governor of Florida was sort of in a PR battle with our hospital because we were asking the state for more money because we're a level 1 trauma safety net, and the infection rates that were starting to become publicly available through the different CMS star systems were really bad at our hospital. And so when I walked into UF Health Jacksonville, literally their infection rates were terrible. The governor was harassing them about it. And I kind of feel like, well, can't get any worse. So we might as well hire this kid from Gainesville. He looks like he knows what he's doing, right? But I think really winning over the staff here was probably my biggest challenge that I was ever like, okay, this was unexpected, but it came out great. Because I had career nurses. I mean, I was not only the youngest person in the room when I was hired as a director amongst the IP staff, but I was leading people who had been nurses for 20 plus years, and getting them from the point of where I'm getting, sort of like the real skeptical looks in the interview, to them saying, hey, thank you. We are a much better department, or I'm moving on to jobs I really love because of you, or whatever. I think that was really kind of an aha moment that, hey, looks like I did okay. Right. And then as a bonus to that, our infection rates have dramatically decreased over the last 10 years. Since, well, not quite 10 years since I've been in the organization. So not only did I get the people on my side, I have sort of lifelong friends from that original group of IPs I led, but then it translated to good patient safety and better outcomes. So that was the big aha moment where I think I felt like I made it.
That's awesome.
People got on my side, right? That's always what
Yeah,
you want.
for sure. And it looks like, correct me if I'm wrong, but you've been in this position now for what, 8 years?
Yeah, about 8 years now. So I was originally hired as the infection prevention director in 2015, and then in 2019, right before the pandemic, they rolled the accreditation department underneath me as well. As most IPs out there know, accreditation and IP are like, hand in hand all the time. So we had some leadership changes in my division, and they said, well, hey, why don't you take over accreditation as well? That seems to line up really well with what you do in infection prevention anyways. And so I've been now over both departments since 2019. So almost 4 years now.
Okay. So and I've asked everybody this, so I don't mean necessarily personally, but more the general infection prevention career track. I mean, how many hospitals are you over now? Is it just a one, or
so I'm over technically 2 hospitals here in Jacksonville, 35 plus clinics, 4 freestanding emergency departments, and soon to be more.
Gotcha. So you're at a system level, where it's at. But what's next? I mean, for infection prevention in general, and we've talked about this before.
Yeah.
But I mean, yeah, you can be over a few more people or over a few more beds or maybe a different population. But ultimately, I mean, this is kind of where everything stops in infection prevention. You get to the system level and you're done. And you had accreditation added to your plate. It didn't sound like it was something you sought out necessarily. It kind of fell in your lap and you've taken it on.
That's right.
But what do you think? What is the next step for somebody in your position, or what do you think it should be? Maybe?
Yeah. So I think it depends on people's aspirations, right? Like, what do they want to do? Certainly, I think infection prevention as a career is a wonderful career. There's lots of opportunities to be effective, to have job satisfaction, to get more hospitals under you and get more, spread. And that's, I think, ideally what a lot of people do want, right? You want to be at the top of your game, gobble up those hospitals, and do the thing. And certainly I've been in positions where I've been either offered jobs that are much more system level versus my 2 hospitals, and they're 6 or 7, or just a larger spread of track. But I think personally, I think infection preventionists, especially once you hit system level or you have multiple hospitals, really need to start thinking operational. They need to start thinking beyond just infection prevention if they have those aspirations, right? As you alluded to, right, normally the track is, right, you become an infection preventionist, you get that first job, maybe you become a senior IP, maybe a manager, then maybe a director, and then a system director at max, right? And then you talk about people like those who are at Joint Commission. Sylvia at Joint Commission is the infection preventionist for Joint, or the person running HCA at the corporate level or whatever. But for me, and what I truly think is infection preventionists at my level need to start thinking, well, can I transfer my skills to something else in the hospital and take on a bigger role? Accreditation helped push me in that direction. It wasn't something I sought necessarily, but it did fall into my lap. And that's put me on the C-suite's radar nearly every single week since I've been in it. Not as a target necessarily, but as a person responsible for keeping the hospital doors open, right? So whether it's ACA or CMS or Joint, I'm now that face for the hospital to do those things, and it's opened up other doors. I think infection preventionists, as a requirement of the job, have to work with everyone. So why not parlay that into hospital leadership roles, whether that's nursing or the operations side or whatever? That's certainly going to be the next stop, I think, for me. And I think for a lot of people in my role, if they don't want to get handicapped by a ceiling of being an infection preventionist, they got to start looking towards hospital operations. It'll open up more doors, certainly higher pay, and just a more robust experience as a leader if that's what they seek.
Do you ever envision infection prevention having its own service line all the way to the top?
Yeah, so I don't know. I think the problem with that is we're, as everybody will say, a non-revenue generating service line, right? And so while we see as we're value added or we can save money by preventing infections, right? The almighty dollar drives hospital service lines, and that's just a fact. And under the insurance, the health insurance, climate in America, that just is what it is. So I'm not sure we'll be a separate standalone service line, but I do think that multiple hospital systems across the nation have made changes to elevate where infection prevention sits in the hospital's organizational chart. And I think that's a good direction. I think traditionally IP departments have fallen under nursing or like I am right now to quality. And I think nursing handicaps infection preventionists because if you fall under nursing, you're treated like a nurse manager or a nurse leader when really we touch every bit of the organization, not just nursing. So I think living under quality is a better move. And I think starting to thin out where you are in infection prevention to the C-suite is already starting to happen. I'm one level in between me and the chief medical officer. And my division director who's over me for quality knows that, hey, if I need to go to the CMO, doors open, go right to them. And I think that puts infection preventionists on a much higher playing field. So as a service line, I just don't think we generate revenue to warrant that. But I do think that I see hospitals changing to put us closer to that C-suite, at least by eliminating the need for us to go into this bureaucratic nightmare of trying to reach the important people. I think that ceiling has been broken, and we're playing ball with the people we need to more and more these days.
That's great. Since you've alluded to it now, obviously with infection prevention not being a revenue driving area, what is your financial argument to others in the organization, whether you need funding or just in general to show the importance of infection prevention in the hospital? What is your kind of high view argument? What are your bullet points you would address?
Yeah, well, first and foremost, patient safety doesn't exist without infection prevention being at the table, right? I mean, we know we've got people who are working on falls prevention and pressure ulcer prevention and things like that, but really we know that infectious diseases and hospital safety culture are getting more important than ever, right? Not just because the patients are getting sicker, more and more boomers are starting to roll into the hospital, right? We are needed infection prevention to keep these people safe, especially in resource-strapped environments when There's not enough nurses to staff the ratios, so the work has to fall somewhere. Infection preventionists have been picking up that slack for patient safety for years now, especially during COVID. So, the second part of that is outside of patient safety, hospitals increasingly more and more are chasing, quality scores, right? Leapfrog, U.S. Health and World News, CMS star rankings, Vizient Premier. Everybody wants to rate you and pay you money based on how well your quality is. And so for us, you want good CLABSI, CAUTI, and lab ID numbers. Well, you need to hire and continue to cultivate a competent infection prevention staff. Otherwise, you're not going to check those boxes. If I mention hand hygiene and leapfrog, most infection preventionists turn red in the face with anger. But that's unfortunately, and I feel the same way, by the way. I have words for the people at Leapfrog. But that's the game we have to play. And so if the seniors, leadership or the board of hospitals, they want to play those games, you've got to put up the money and the funding for staff to be able to accomplish those missions. And so I think the quality consortium groups and the rankings and the ratings, hospitals are continually trying to get a leg up against each other to convince people to come in their doors and to convince health care insurance companies to keep paying them more money. And infection prevention plays a part of that. So, between true patient safety, preventing infections, sending patients home healthier, and chasing quality scores, I think it's a no-brainer to invest in your infection prevention departments, because that work's not going to fall to anyone else.
Let's talk about management. You had a ton of management skills that you picked up in the military, and then that's obviously translated to the infection side too. Mm-hmm. When I first met you, I think probably back 2015, 2016 at one of the national APICs. And I've seen this consistently, not this year because you didn't bring a team with you, but you've always brought a team of IPs that seemingly just in the week that you see them, everybody loves and cares for each other. It's a very supportive group. Everybody seems to get along. And that always stood out. So I'm just curious, what's your philosophy on management, I guess, team building and establishing a culture specifically within the infection prevention department?
Yeah. So let me tell you, establishing culture and building teams is hard work, right? In the military, sometimes you don't really get to choose your team, right? So it's just here's the next person, fill in the role. In the hospital side, it's more difficult, right? And if you have difficult work to do, it's imperative that you have a good team. And figuring out how to put that together has been a real challenge over my career. And I think now, right, I joke with my manager who's under me that, it's taken me 8 years to get the team where I wanted them to be, right? Because it's hard work. Doesn't mean we didn't have wins along the way, but, I think in terms of my strategy, it's first and foremost, make sure that everybody is on the same playing field when it comes to education, knowledge of the job, right? You want everybody to be offered the same resources and be at the same place. That way we can have those team conversations and nobody's left wondering, well, what does he mean by that? Or what does she mean by that? We have an equal number of people who have been educated, they've been standardized, and now we can have those conversations that move the needle. I think second is, as a leader, I won't ask you to do anything that I'm not willing or capable of doing myself, right? Now, I came up through infection prevention, having to learn, the nitty gritty of the different, electronic health systems, the different infection control surveillance systems. But as a leader, I like to know that what I'm asking my team to do, I can also stand in and do myself. Now, as my team has grown, things have become more complex. I can't do their individual day-to-day jobs all the time, but I can say, what do you need? What can I do to help support you to do this better, faster, quicker, whatever? And I think being that sort of, the cliche of being a servant leader, really for infection prevention, I think is important, because you want to make sure that with the ever increasing pressure to do better from a reportable data standpoint, is my team getting the things they need to do the job we're asking them to do? And if that answer is yes, then I think I'm doing a great job, because then the numbers and the indicators start to follow. So I think for me, it's picking the right personalities to succeed on the team. Picking a good multidisciplinary team, I think, has been important, and then supporting them with whatever they need: education, stuff, equipment, time, and flexibility. I think has been a real key, to building our team here. especially as you can look around you and something like 60% of households have at least a bachelor's degree and somebody works from home, right? In the hospitals, we traditionally have not been a work from home culture, but adding that flexibility in for infection prevention teams, I think, is a big job satisfier. So trying to meet the generations where they are and what they think they need and what we need, I think is gonna be a win for everyone.
Quick
Yeah.
sidebar question: the remote work in infection prevention. I mean, I've seen it. I mean, it was big for a second. I feel like it's really industry wide. It's drawn back quite a bit. I think there was at one point it was like 60% of overall jobs in the U.S. were posted with the remote option, and now I think it's below 4%.
Yeah.
So there's been kind of a fallback from it. But as far as the way you see infection prevention work, is that something that can be done remotely, or is that something that is one of those things? No, you need to come be here every day for a year, and then after you kind of get a handle on what's happening, then you might be able to. What do you think is possible?
Yeah, so I think it's addressing two questions there. So first and foremost, for people new to infection prevention, I do think it's a requirement to be in person, right, for at least some amount of time. You need that interaction. You need that base level education from your peers to get where you can then effectively be, a work from home person. So I think for new staff, I think it's imperative that they spend some amount of time acclimating to infection prevention in person. That said, when you look at it from that point of now they're educated, they know what they're doing in infection prevention, I do think a certain amount of IP can be done from home remotely, but there still has to be some in-person, interaction there. I think we've got somewhat of a hybrid model here at my current hospital, UF Health Checks. I'm here almost every day because of my other roles, but my team gets at least 1 to 2 work from home days because at the end of the day, yes, we got to be bedside, we got to be doing the checks, but there's also a fair amount of surveillance work and electronic health record work that you can be anywhere and do that. I don't need you necessarily to come in and sit at your desk, waste your gas money, and do that whole commute in order to come here and sit on the computer for 8 hours, right? So I think there's a nice happy medium somewhere that I think a lot of hospitals have tried to figure out and have found. And as long as they have senior leadership supportive of it, I think it works well. Some hospital systems that are very large have gone to strictly remote only infection prevention for their surveillance. And then they have a couple of clinical folks who come in and do the rounds. Well, I think it's probably a factor of finances and trying to figure out the right balance for the right systems, especially if you have multiple hospitals. I find that there's probably a little bit of a non-congruence between the people at the bedside and the people doing the surveillance. I think it's very difficult to convey sort of what you're seeing in the chart to what's happening at the bedside if you don't have some level of back and forth in between those two. Not saying it can't be done, but at least in our hospital, we found it most effective to have a mixed mode. So we rotate our staff. We always have at least 2 to 3 staff members in person any given day, with the other 2 to 3 staff working from home and then rotating. And I think that's probably the sweet spot of where you want to be.
Interesting. Yeah, I've seen hospitals try it a million different ways. So it's interesting. All right, changing lanes a little bit. Obviously, you've been a member of APIC for years, and you've gone to the national conferences. How involved are you locally, or are you involved locally? And then how important is that affiliation and maybe others in this particular profession?
Yeah, so I am involved locally with the Northeast Florida APIC chapter. We've grown it exponentially over the last several years. I was a board member for them for quite a few years. I've stepped back a little bit from the leadership positions of our local APIC just because my multiple hats of the military and accreditation and the other departments I have. But I do think it's really important. And so I think getting the other hospitals together, especially if you're in a big city, and kind of comparing notes, I think is helpful for a variety of reasons. I think first and foremost, it helps others get the information they need to take positions with their senior leadership. Well, hey, UF Health Jacksonville is doing it this way, and they have the worst of the worst patients. So maybe we want to look at that. And vice versa, right? One hospital might say, hey, we've been seeing a lot of C. diff. What about you guys? Well, we haven't. So, what can we do to help you through that? So I think sharing notes versus competitiveness is really useful for the local APIC chapters, because we do share patient populations across our city. We do share sometimes staff, right? At one point, two of the other hospital systems in town were staffed by folks who used to work for me and were now leading other hospitals. So, we know them and they know us and they know what those expectations are for their own hospitals, but it does help to be involved with that local chapter to see what else is going on, or to say, hey, that product rep that keeps bothering you at your hospital, I kicked him out of mine, and so that interaction amongst the others is really helpful. I think there was some level of maybe we don't want to share secrets with others, but at the end of the day, local chapters are so powerful because we all share the same population, in our cities, and we can look at each other's notes and make changes, together. Now, I think the national chapter I've been a member of for many years. I've attended many of those conferences, and I think it's a good background of information that's available as a member for Big APIC. I do think that they probably need some modernization too. I think that my personal feeling in infection prevention, and maybe this is controversial, maybe not, but as we talk about career ceilings and ladders and things like that, I think Big APIC needs to pivot from this is our stance and we're needing this out of people to starting to rub shoulders with the healthcare executives in a different way, right? So the only way our field is going to get elevated is if the C-suite stops thinking of us as an ancillary department and one more that should be interthread within the backbone of their operations. And we've been able to do that here in Jacksonville, and I've seen the fruits of that, because our C-suite is so in tune with what we're doing, and us, them, we are involved with everything from building construction to the capital budgeting process. My COO says, well, was Chad's team involved with these capital budget requests? And well, now capital budget requests for everyone have to go through our department, depending on what they're doing. And I think that's really important to elevating not only the field, but also our leadership stature. I don't want people to think of me as an infection preventionist at this level. I want them to think of me as a leader. And I think that's where APIC needs to go. We are training and breeding healthcare leaders instead of just infection preventionists. And so, that's kind of my soapbox. And I think, Devin Jopp and others have probably heard it through my feedback that I think the field needs to diversify a little bit, start doing things differently, stop asking for money, stop asking C-suite for help, and instead get it with C-suite, be on the C-suite, help them understand what you're doing, and then you won't have to ask for money. You'll just be seen as another person there at the table with them. And I think that's where we really need to go.
Yeah, no, it makes sense to me. I'm trying to think. I want to talk about, in our last few minutes here, I want to talk about the media. I want to talk about the media appearances you've had. I'm sure you had done it plenty before COVID came through, but I think I remember kind of following it and seeing you pop up on national news and being like, oh wait, that's Chad on the screen here. So I don't know if you rose a level during that time, but where was your first opportunity to kind of speak more publicly like that?
Yeah.
And then kind of walk us down kind of how this is all transpired.
Yeah.
And then I might have a follow-up question after that.
Yeah. So I think back when I first started here in 2015, our hospital had some infection prevention issues, right? And so it was well publicized. And so our internal media folks would latch on to anything good that was happening with infection control, right? Because they wanted to publish that. And so they started doing internal stuff. Oh, we interviewed Chad and he's our infection control director. And they'd put me in front of the hospital staff or whatever. And so they tried to start publicizing that. So then when the Ebola pandemic was happening, right? Well, we need local experts who can talk about this. And they said, well, Chad, your team knows a lot about this. Why don't you just talk to the news? And it was like, me? Okay, I mean, I guess, right? If you're the person in the room who knows it and they ask, you want to answer that. So I started doing things about Ebola preparation and things like that with just local news. And then COVID happened, right? And then that just completely exploded the amount of media requests coming, to the community. And so Why me versus someone else? Well, I think it's probably because our organization here in Jacksonville, we seek to be right the leading, experts on what we do, and we have a very low amount of sort of bureaucratic red tape when it comes to media things. And so, at the time, our then CEO, Dr. Leon Haley, said, "Well, Chad's the expert. Why do they want to hear from me? Put Chad on the news, right? He's the guy." And that was it. And so we became the hospital that all the news agencies would go to first to ask to talk about COVID. Yes, we were the safety net, so we had a lot of COVID patients that were really sick, but we're the academic hospital of Jacksonville, and we wanted to put that expertise to work. So once I started doing it for one station, then the next station locally started calling, then the next one, and then somehow somebody from national news, picked up, probably because we're in Florida, and Florida was well publicized for a lot of things during the pandemic, a lot of it not good, but we did end up on national news. And because we kept saying yes to the media, more people started asking. And as I grew more comfortable in media interviews, then those requests started coming straight. Well, we want to talk to Chad. Because Chad, speaks in small sentences, or easy to digest, or he doesn't look flustered on camera, right? And which I was initially. It was like, oh my God, like what? I don't want to be on the news. But with time, you keep doing something, you get better at it, and that started happening. So after a dozen or so interviews, I sort of became the COVID person for Jacksonville, and then after 25 or 50 interviews, then it became I'm the COVID person for Florida. And then it became national, where CNN wanted to talk, or NBC News, or BBC, or wherever. And then this funny thing happens in media where like the local channel will pick you up. And then my mom in Orlando sees me on her news. And she's like, I didn't know you did something for Channel 2 News in Orlando. And I said, I didn't. And she's like, there you are. And so then you realize the news agencies in the state start sharing amongst each other, right? NBC talks to NBC there, and so then it just gets completely out of control. But I think I think the number one thing is, right, we wanted to educate. We wanted to be that confident source in a sea of misinformation that people can come to UF Health Jacksonville, look at me or whoever on camera, and know that, hey, we're telling you the truth because we are one of you. We are a local, we live here, and we want the best for our community. And it just kind of proliferated from there.
So it wasn't something that you necessarily sought out. You're not sending out emails saying, hey, I'd love to have a chance to do this. So it wasn't some like self-promotional thing. Okay, so this is good. This is interesting. Now that it's happened, do you wish you would have said no? Or like what's the feedback from it? Like now, are you kind of like kicking yourself, or are you like, no, this was really good for me personally? I mean, how do you reflect on it all?
Yeah, well, it's really interesting when you see a lot of the papers that came out post-pandemic about, the state of infection prevention and the burnout factor. Certainly there could be burnout, right? I mean, during the peak of the pandemic, it would be nothing for me to have 6 interviews in one day, some national, some local. And it was hectic. I felt like I was just going from one interview to the next. But, I did feel like I'm the expert, right? I'm supposed to be the one to know this stuff. And if I didn't do those things, people would suffer, right? And I think somewhat that was rewarded by me actually running into people in the community and saying, I saw you on the news last night, and I convinced my mom to get vaccinated. Or even some of our employees in the hospital, right? We have a very smart group of employees working here, but they fall prey to misinformation too. And so, one of our older ladies who works in our gift shop, I think she's closing in on 90, said, Chad, you're the reason I got vaccinated, because I saw your interview. And then I pointed to the ladies in church and I said, I know him. You need to listen to him. And I think that kind of makes you feel a little more energized, like, hey, like what I'm doing actually does matter. And so definitely it could be taxing at times. I got a fair amount of hate email, threats, and everything else during the pandemic via social media, my email box, my house. I fell victim to a lot of that stuff too. But at the end of the day, it's those people that say, hey, I was able to convince someone to get better or to get vaccinated, it makes that kind of stuff worthwhile. I think it continues, right? So I still get interview requests. Basically, any infectious disease that pops up in the news now, I get calls for it, right? So the leprosy in Central Florida that was recently, I got calls about that. The malaria cases in Tampa, got called about that. Chad, can you speak to this, right? And so, if anything, it's probably increased our hospital stature as a center for people to look at for expertise on infectious diseases. Professionally, I wouldn't say it's opened any doors for me or anything like that. I do have some recurring, spots on NPR channels here and there, but it's not monetized or anything like that. So, people should know, right? You get paid nothing to do anything for the media. You're doing it for, basic edification of the people you want to educate or your own self glamour. But I have not made a dime off of any of it. So,
got it. All right. I think that's all I've got, and I don't want to keep. I've already kept you.
No, you're fine. My calendar is always crazy, as you know. So.
Yeah, no, I can go. Well, last thing then, is there anything you want to be sure to say, or another rant or soapbox you want to give just for what we're doing? Or
yeah, I mean, I think if anything, I would just tell infection preventionists, don't limit yourself to infection prevention, right? I think if you have a passion for it and this is what you want to do your whole career, great. Follow what you love, right? I really have a passion for leadership, and that leadership extends beyond just infection prevention. And I find it that when you climb as an infection preventionist to leadership in hospitals, well, if they will listen to you as an infection preventionist, then they will listen to you for basically anything else, right? We're the ones keeping people safe during pandemics and during COVID and Ebola. And so it's made my job easier for accreditation because they see the results that infection prevention has had, and they think, well, Chad knows what he's doing, so we should probably do what he's asking us in this other realm. And so I definitely want to encourage people that if you are a director or a system or corporate director, there's still more out there for you. Translate your leadership into other, consequential hospital jobs if you feel fit to do that. We work with everyone. We have to deal with everyone. It makes sense then, to be able to escalate your careers into a hospital operation standpoint if you want to. And for those who are young in the field or trying to break into it, there's a lot of resources now that we didn't have back in my day, right? The AIPC, certification didn't exist. Hospital internships for infection prevention didn't exist. We didn't have education tracks in our MPH degree for infection prevention. All of that exists now, and it's all because of the efforts of people in my cohort and ones older than me who have been pushing these things for years. So, I'd encourage people to take advantage of those opportunities and those resources and do some real good for patient safety.
Let me get one more question.
Sure.
Then, unless you're having to.
No, go ahead. Out. My 1 o'clock canceled. So.
No. Okay. Yeah. So, and I meant to ask this earlier too, but there's been obviously leadership is a big part of your career. Yeah. Both the different spaces now, and that's obviously something you can kind of, I don't know, set your hat on. I don't know what that phrase is.
Yeah.
But you've had a lot of IPs that are now system leaders around the country. So you somehow instilled some leadership, whether it's confidence or ability, into these folks early on in their career.
Yeah.
Like I said, I mean, you've got a handful that have progressed very quickly compared to others. So I'm just curious, you hit on culture and you talked a bit there about how important it is to kind of see with the big lens as far as what you're capable of. But how are you, I don't know, I mean, how are you mentoring these people to really grow as quickly as they have?
Yeah. So, it's a good question. I think it's multifaceted, right? Because when I've hired some of these individuals, I knew that they were going to be fast burners, right? I knew that we'd probably only have them for a couple of years, but if I can get them to do really great things for me and, serve their own career purposes, I wanted to help them, right? People like Marco Predic of the HCA system in the capital region, I knew Marco was going to be a star, and I brought him on board. He was an intern in Gainesville, and then he was looking for a role, and I was like, perfect, you've been working in Gainesville. I worked in Gainesville. I know the guy you interned with because he was my intern, right? And so John Delano up in, I believe, the Aurora system in Chicago area. So he was one of my interns as well. So I saw Marco coming through the system. I was like, this kid's going to be a star. Like, I want to get him where he wants to go. But I got to train him first, and then he's going to do great things. And sure enough, he did, right? So same thing with Melody Wu-Ballis in the Mayo system here in Florida. She was one of my staff members too, and she wanted to do more, and I supported that. So I think finding those good, talented individuals and saying, look, I know you're probably not going to be here forever, but I want you to do your absolute maximum while you're here, and then I'm going to help you get to your next level, whatever that career is. I think has been really great for people who have worked under me, because it means I'm supportive not only in getting them the resources to succeed here, but also for their future career. Somebody gave me a chance a long time ago, whether that was my first IP job at UPMC or my first director job here at UF Health Jacksonville. And I never want to be that roadblock for someone else. I want to help people, get to those levels that they want to get, because look, they're going to leave eventually anyway, right? I would rather them leave, fully trained up, having done really great things for UF Health Jacksonville. That way, when they go on, they can look back and say, you know what, that was a really foundationally awesome experience I had. And I want to then transition that to someone else, right? Like Marco is in his AVP role is going to mentor interns, right? Melody, at Mayo Jacks, she's going to intern people as well and bring them on board, right? It's just kind of breeding goodness, right? Next one generation of IPs after another, and I'm really a big believer in that.
And you mentioned being able to identify these folks that were going to be stars.
Yeah.
What's the individual skill or trait that you can kind of associate with all of these folks that you've hired?
Yeah, well, I think really it's looking at people and knowing that they want to do good, right? Everybody can get through an interview. Yeah, I want to do this, I want to do that. But I think seeing that people have aspirations really helps, right? I had aspirations when I was hired, and when people have those aspirations to climb higher, for the most part, they're willing to put in really hard work to get there, right? And I think identifying that in people has been really helpful in sort of spotting these kind of future superstars. And they're also just good teammates, right? I mean, if you get someone who comes in the first day and is like, I want to be a CEO. Okay, that's great, but you have to first start on the lowest level before you start thinking about that. And so, sifting through people who have these, grandiose aspirations, but can't back it up versus those who are willing to do the hard work to get there, I think is really how you kind of identify people in that way. And I think it's when people put themselves out there, people are willing to help and do extra work before they get to you. I think that helps, right? I mean, people like Marco Predit, he was an intern at Gainesville, and he, really worked hard for them there. John Delano at the time was there, and he said, look, Marco's great. I would hire him if we could, but we don't have the space. That's what I want to hear, of people working hard to achieve sort of that team goal. And then I'm going to help you get where you want to get. And so I just think it's really important to spot those people who have that potential, who are hard workers. And maybe some of them don't know they want to be leaders, but they develop into that because they're content knowledge experts and they have good team and interpersonal skills. And I think spotting those people early, has been really easy for me, but also anybody can do it. You don't have to have an eye for leadership potential. You just have to spot the hard workers and develop that leadership in them.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.